Hi, welcome everyone. Greetings to our LBDA community. We've been on hiatus for a little bit with summer here, but we're back with you and excited to present session 13 in our 2024 webinar series, Empowerment Through Education. I'm Julia Wood, the Director of Professional and Community Education here at the Lewy Body Dementia Association. And today we're going to be switching gears. We did a little wellness workshop recently and did some exercise. Today, we're going to discuss sleep symptoms in Lewy body dementia with Dr. Bhavana Patel from our Research Center of Excellence at the University of Florida. But before we get started, a few words about the Lewy Body Dementia Association. We are a national nonprofit dedicated to maximizing the quality of life for those affected by LBD by providing comprehensive education through events like this, compassionate support for those living with LBD via our Lewy line, and we also work to advance efforts to increase awareness for research. So a few housekeeping items. You can select at the bottom, you've got a little toolbar, and you can select the show captions at the bottom of your Zoom toolbar at any time during the presentation to launch closed captioning. You'll also notice that there is a resources tab down at the bottom in that same toolbar, and that has links and downloads for this presentation. If you're having any trouble getting those, let us know. We know last time we had to kind of tweak some things on our end to get those to show up. You're also welcome to submit your questions throughout the presentation using the Q&A icon at the bottom, so that question and answer feature. And then following Dr. Patel's presentation, we'll address a few questions from the audience pool for about 15 minutes. So exciting news to simplify access to these events. We've added a ribbon on our homepage that directs you to our website page where you can register for upcoming webinars and where you can find that link to our YouTube channel, LBDA TV, to watch the recordings of past webinars at any time. This presentation is being recorded, and an email will be sent to those who registered with a link to view the recording in about 1 week. And Rose will drop that link in the chat as well. Lastly, when you leave the session today, a brief survey will appear asking for your feedback about today's presentation. Please take a moment to complete that survey to help inform our future content. We're currently planning for 2025, so help us out. Now let's learn more about who is joining us in the audience today. So Rose is going to launch that polling question so we can see who's with us. And if you recall, we added recently where you can select more than one. So you might be a person with Lewy, and maybe you're attending this with your care partner or with a family or friend. Maybe you're a healthcare provider. We've got a few researchers and scientists, it looks like, and then maybe some others. So we'll take a look at this here and see. Typically, our care partners are our biggest audience, and we love you for it. But we'll kind of get an idea of who's in the audience with us today. Okay, excellent. So it looks like we've got about 25% of you are people with LBD or with symptoms. Then we've got almost 50% of your care partners. We've got about 20 healthcare providers, or about 10% of you. We've got some family and friends, some researchers, and then some others. And so, as I've said, you are all welcome. We're glad to have everyone here with us. All right. So with that, let's move on here. So, Dr. Bhavana Patel is our presenter today, and she is currently an assistant professor in the Division of Movement Disorders and Behavioral Neurology at the University of Southern Florida, or University of Florida. I'm sorry, I should not have said Southern Florida. Dr. Patel has a personal connection to Lewy body dementia, and during her training, she completed additional clinical and research training in LBD. In 2018, she was the inaugural recipient of the Clinical Research Training Scholarship in Dementia with Lewy Bodies from the American Grain Foundation and the Mary E. Groff Charitable Trust in collaboration with the American Academy of Neurology. Dr. Patel's research interests include improving the delivery of specialized healthcare in LBD, applications of technology to improve health outcomes, and neurostimulation for movement and cognitive disorders. So with that, please welcome Dr. Bhavana Patel. Dr. Patel. There we go. Welcome. Thanks so much for joining us today.
Thank you for having me.
Yeah, we're really excited to hear more about sleep symptoms. This is something that we get a lot of questions about. And I know you're going to ask them some questions so you can kind of see what types of symptoms they have going on. So I'm going to hand it over the presentation to you so you can share screen. Thank you so
Okay,
much.
awesome. Thank you. All right, we're going to get started with some questions, similar poll here. So first, I'd like to know, is your loved one having any sleeping problems? So looks like there's a large number of you who have observed some sleeping problems in your loved one. That brings you here today. My next question is going to be for the care partners. Are you affected by your loved one's disturbed sleep? And it looks like many of you did answer yes. Nearly 83% of individuals who are care partners on this webinar today are affected by their loved one's sleep. My next question is, do you frequently discuss sleep issues with your neurologist? All right, it's actually sort of split. So 63% of individuals did say they do discuss their sleep issues with neurologists. However, nearly 40% do not. All right, and we'll talk about that during this presentation today too. And my last question is, does your loved one have the following? Or do you have the following? REM behavior disorder, excessive daytime sleepiness, insomnia, restless leg syndrome, or obstructive sleep apnea? So similar to what has been reported in Lewy Body, everyone on this webinar today has a loved one or is affected by REM behavior disorder, or majority of the individuals, 66% REM behavior disorder or excessive daytime sleepiness, followed by insomnia, restless leg syndrome, and obstructive sleep apnea. All right, we'll be going over all of these sleep disturbances during this presentation. So now I will share my screen. So the title of this webinar is Counting Sheep with Lewy, Coping with Sleep Disturbances in Lewy Body Dementia. And just like Julia mentioned, I am a neurologist who specializes in both movement disorders and behavioral neurology, leading to my interest in Lewy body dementia as it encompasses both areas of neurology. So these are objectives that were shared with you beforehand. The first objective of today's webinar will be to define the common sleep disturbances that occur in Lewy body dementia and their presentations. I want you to learn strategies on how to manage these sleep disturbances. And I want you to know who to reach out to discuss these sleep issues and potentially medications that can help you or your loved one. So it's very important to recognize that at least one form of sleep disturbance may be present in as many as 90% of people living with Lewy body dementia. That's a very large number. So I'm so happy that you are here today to learn more about sleep disturbances and how we could manage them better. First, I like to start off with this slide because it's very important. I want everyone to understand that sleep is very important for everyone, for the person with Lewy body dementia, for the care partners, for the family members. The benefit of sleep is really that there are many systems at play when you are actually sleeping at night that come out and clean up your brain. What I like to say they're like garbage collectors. They come out at night and collect all this metabolic waste and proteins that do not belong. But if you do not get good sleep, you don't allow those garbage collectors enough time to clean up all that waste. And then it just builds up night after night, month after month, year after year. And hence why poor sleep is actually associated with memory and thinking changes over time, along with mood changes, poor quality of life. So sleep is very important. So what kinds of sleep disorders occur in Lewy body dementia? For the duration of my talk, I'll go over what type of sleep disorder it is. So what is it? We'll talk about how can it be diagnosed and what can you do about it? So some common types of sleep disorders that occur in Lewy body dementia. 1, REM behavior disorder, excessive daytime sleepiness, insomnia, restless leg syndrome, and obstructive sleep apnea. So we'll start off discussing REM behavior disorder. So what is REM behavior disorder? It's defined as REM sleep without atonia on a sleep study. What does that really mean? It means that you actually lose the ability of your muscles to completely relax during REM. Normally, there are signals sent from your brain to your muscles that say, just completely relax, let your muscles relax, and do not react to any dreams or anything that you may be experiencing. But that reflex is lost in this disease. That leads to dream enactment behaviors, which sometimes can be violent. They can disrupt the sleep cycle because you can have arousals due to this dream enactment. And that can, of course, lead to daytime sleepiness and fatigue because you're not getting good rest at night. So when a person with REM behavior disorder is asleep, it may look like they're acting out a bad dream, and they may have muscle twitches, or their arms or legs may move. They may talk, shout, or scream, or they may just make mumbling noises. They can kick, punch, or grab the air, or actually, accidentally hit their bed partner. They may jump or fall out of bed. And this can result in injuries to oneself or bed partners. So REM behavior disorder is actually very common in people with Lewy body dementia. And one study actually has shown that up to 76% of individuals at autopsy who did have Lewy body did have REM behavior disorder in their lives. It is highly prevalent in Lewy body dementia that is part of the core diagnostic criteria. So how do we detect REM behavior disorder? It's mostly by history. One of the questions I may ask my patients may be, have you ever been told or suspected yourself that you seem to act out your dreams while asleep? And give examples such as punching, flailing your arms in the air, making running movements, etc. Another question that can be asked, and both of these questions have very high sensitivity and specificity of detecting REM behavior disorder, is have you ever seen the patient appear to act out his or her dreams while asleep? If yes, how long has it been going on for? And has the patient ever been injured from these behaviors? Or has the bed partner been injured? And has the patient mentioned these dreams of being chased or attacked, where they end up defending themselves? And if the patient woke up and told you about a dream, did the details of the dream match the movements that they made while they were asleep? But a formal definitive diagnosis can be made by a video sleep study, which is done in a sleep lab. Oftentimes, sleep studies done in the home setting do not have all the sensors that are required to adequately detect REM behavior disorder. So a sleep study should be done in a sleep lab, as demonstrated here. I get this question a lot. Is REM behavior disorder dangerous? So it's not dangerous and it's not harmful, but it can be. It can be if you end up hurting yourself or someone else. So the first thing I like to discuss is bedroom safety. So removing dangerous objects from the bedroom, such as sharp items and things that can be used as weapons, or even the nightstand that has a sharp edge, which is right next to your bed, which you need for your glass of water or pills. But if you're having a vivid dream, acting out your dreams, and it's possible that you can roll out of bed, hit your head on that nightstand, it's probably not wise to have that nightstand right next to your bed. I recommend moving it a little further away where you could still reach it, but it won't hurt you in the event that you were to fall out of bed. You can put padding on the floor or around the bed as long as it's safe and it's not something that you could trip over. And in certain selected situations, recommend placing barriers on the side of the bed. This is very selective and it's depending on the individual. And again, something that needs to be discussed with your doctor, because one risk of putting a barrier on the side of the bed, such as a bed rail, is that the person with REM behavior disorder could become entangled in the bed rail. So it's very selective. Important to move furniture and clutter away from the bed. Protect bedroom windows, especially if the bed is right next to a window. And bed partners can consider sleeping in a separate bed or room, at least until the symptoms are controlled. Sometimes I have patients have two beds side by side, but just put enough space in between them. So that way they are less likely to get hurt. Additional ways you can manage REM behavior disorder include checking with your doctor if you are on medications that could worsen it. Sometimes medications are actually needed to treat certain symptoms that are also part of Lewy body dementia. However, at times they can also worsen REM behavior disorder. So it's important to discuss risk versus benefit and even timing of medications. We do have some treatments for REM behavior disorder. These have not been as well studied. However, the evidence does support use of melatonin, starting at 3 milligrams up to 12, and some reports will say even up to 18 milligrams, about an hour before bedtime to help with REM behavior disorder symptoms. Additionally, there is a prescription medication called clonazepam that is a controlled medication that can also be used at doses of 0.25 up to 1 milligram, typically in the management of REM behavior disorder. In rare situations, higher doses may be even needed. And these can be prescribed and discussed with your neurologist and or sleep medicine physician. And lastly, we may use a combination of both melatonin and clonazepam to help the symptoms of REM behavior disorder. So if your loved one is affected, or if you have Lewy body dementia and are affected by REM behavior disorder, it is important to talk to your neurologist about management, specifically medications. Review your medications that you're currently taking, the timing of those medications, and what else you can be prescribed in order to help with your symptoms. I want you to realize that, it's very common that people may say that they experience REM behavior disorder for certain periods of time, and then they don't experience it for months at a time or weeks at a time, and then it comes back. We're still beginning to understand more and more about REM behavior disorder and why some of these fluctuations do happen in the course of someone's life. And of course, you can ask for a sleep medicine referral to further help manage the REM behavior disorder. We'll move on to the second most common sleep disturbance that is seen in Lewy body dementia, which is excessive daytime sleepiness, that I understand many of you on this call are affected by in one way or another. So what is excessive daytime sleepiness? Really, it's difficulty remaining awake and alert during the day. So you have this overwhelming and persistent sense of sleepiness during the daytime. It can impact a person's quality of life, interfere with your daily activities, and increase the risk of accidents. There's been research showing that excessive daytime sleepiness has been associated with car accidents. It can also be related to multiple causes, especially related to other sleep disorders. It is more prevalent in Lewy body compared to persons with Alzheimer's disease or healthy individuals. I think that's very important to realize that individuals with Lewy body dementia do experience excessive daytime sleepiness compared to individuals with other dementia syndromes. So one study did demonstrate nearly 50% of individuals with dementia with Lewy body and 57% of individuals with Parkinson's disease dementia experience excessive daytime sleepiness, compared to 10% in age-matched controls, meaning healthy individuals, and 18% in individuals with Alzheimer's disease. And the prevalence of excessive daytime sleepiness actually increases as the disease progresses, as the changes in the brain are advancing. And it increased to 85% for individuals with Parkinson's disease dementia and 75% in those living with dementia with Lewy bodies after 2 years. So what leads to excessive daytime sleepiness? So poor sleep due to other sleep disorders, medications, sometimes prescription sleep medications can cause excessive daytime sleepiness if they're taken too late in the evening. They may have some residual effects the following day. Certain dopamine agonists, pain medications, antipsychotics, some antidepressants, and substances such as alcohol or even medical marijuana. Mood disorders can also cause excessive daytime sleepiness, and changes in the brain due to the disease itself. So how do you know if you have excessive daytime sleepiness? So there is this questionnaire that frequently we may ask individuals called the Epworth Sleepiness Scale. Of course, you may be aware of yourself having a difficult time staying awake during the day, or you may observe your loved one may have a difficult time staying awake and may need more naps. But we frequently use these questions, and is based on how likely are you in the past 4 weeks to doze off in these various different situations. And if you score greater than 10, that means there's a high chance of you dozing off, meaning there is a significant amount of daytime sleepiness present. Other tests that may be done to detect excessive daytime sleepiness include a test called the multiple sleep latency test, where we can measure how quickly an individual falls asleep in a quiet environment. And another test that's also available that can be done by a sleep medicine specialist is a maintenance of wakefulness test, which can measure your ability to stay awake actually during the day. So how do we manage excessive daytime sleepiness? So treating other conditions that may be contributing to your excessive daytime sleepiness is very important. So treating the REM behavior sleep disorder, or if you have obstructive sleep apnea, that treating those can actually may help your excessive daytime sleepiness. And short medications that may cause sleepiness are actually not taken during the day, and they are taken at night. And limit or discontinue the use of alcohol or marijuana or medical marijuana. It's important to have a routine, and this includes a daytime and bedtime routine. What that means is setting alarms to not only wake up, but set an alarm when you should go to sleep. Expose yourself to sunlight during the day. And consider adjusting the timing of your memory medication, which may be a cholinesterase inhibitor, such as donepezil or Aricept, galantamine, or rivastigmine. Moving it to the morning may help with alertness and attention during the day. Exercising earlier in the day can help. And schedule time for activity and rest breaks. There is this great resource on the Lewy Body Dementia website that will be posted in your resource section about tips on how to cope with daytime sleepiness. Next, we'll talk about insomnia. So what is insomnia? Insomnia is defined as an inability to sleep, where people will report difficulty falling asleep. They may have trouble staying asleep. They may wake up early. And this can be episodic, meaning it can be situational. If something traumatic happened in someone's life, they may be losing sleep or have difficulty falling asleep during that period of time, but it self-resolves, and we would expect it to resolve as time went on. But chronic insomnia is defined as having difficulties sleeping 3 nights a week for at least 3 months. And this should require treatment. And it can be due to multiple reasons, including mood disorders, such as anxiety, depression, urinary frequency or urgency, needing to wake up in the middle of the night to go to the restroom, and then having difficulty falling asleep after that. Medications can also contribute to insomnia. So again, it's important to talk to your doctor if there is a medication that you're taking at bedtime that's actually causing you to stay awake, or if you're taking it too late in the day. And other sleep disorders, along with the physical symptoms of Parkinsonism. So individuals with Lewy body dementia may frequently experience stiffness, slowness, and or tremor that may be impacting their ability to fall asleep or stay asleep or wake up early in the morning because they may experience muscle cramps. And of course, underlying changes in the brain related to Lewy body. And insomnia can actually worsen cognitive decline, increase daytime sleepiness, because if you're not sleeping at night, you may want to sleep during the day. And it has been shown to worsen behavioral symptoms in Lewy body dementia. So it's really important to address this as well. There's no formal test available for insomnia. It is a clinical diagnosis based on the history that is provided by the person with Lewy body dementia and their care partner. So some questions I may frequently ask include, is there difficulty initiating or maintaining sleep? And are you waking up earlier than desired, or are you waking up in the middle of the night? And insomnia can actually lead to social, occupational, or distress in just other areas of functioning, including maintaining relationships and just overall social interactions. People can have daytime sleepiness, fatigue, irritability or mood disturbance, behavioral disturbances. And the other part I always ask about is how long has this been going on? to help me decide, is this brief insomnia or situational, or is this chronic insomnia? One way to actually get a good idea if someone is experiencing insomnia and for how long and what can I do about it, I like to incorporate something called a sleep diary. A sleep diary is a self-report of these various aspects of sleep, sleep hygiene. So that includes time to bed, including naps, time lights went off, time lights went on, and total time slept asleep during the day and night. Here is an example of a sleep diary that you would complete when you would wake up. Oftentimes, we like to collect this information over a span of 2 weeks. Again, collecting what time you went to bed at, what time did you fall asleep, and when you did fall asleep, was it easy or hard for you to fall asleep? How many times did you wake up during sleep? I always like to find out if it was related to a spontaneous awakening, whether it was muscle cramps, Parkinsonian symptoms, or the need to go use the restroom. And then what time did you get out of bed at? How many hours of sleep did you get at night? And if sleep was disturbed, what was that reason? And how did you feel when you wake up? Then we also like to complete the same information for bedtime as well. It's also important to note if there was any caffeinated or alcoholic beverages that were consumed prior to going to sleep, and actually even just what time. Oftentimes, I recommend no caffeine after noon, as caffeine has a long half-life and can linger in your system, affecting your sleep when it comes to bedtime. So some non-pharmacological strategies in managing insomnia. It really involves good sleep hygiene. What that means is turning off the television, any computer or other electronics that can be stimulating, and avoiding disturbing media throughout the day. I've seen a lot of patients have insomnia because they're thinking about the news that they watch during the day, and really making sure you're not watching anything that could be scary or disturbing in the evening time. This includes TV shows, news, any print or electronic media that can be disturbing. Avoiding foods and beverages that can affect sleep for several hours or more, such as caffeine, alcohol, that can affect your sleep directly, and spicy foods and fatty foods. Sometimes that can cause GI upset or heartburn that can affect your sleep as well. Restrict napping late in the afternoon. So it's important to have limited naps for a limited duration of time as well. So that way you're not impacting your bedtime sleep. Exercising earlier in the day can actually help with sleep, but if you exercise too late, it can be activating and can interfere with sleep. So recommend exercising earlier in the day when you're feeling good, such as in the morning or early afternoon. And developing a bedtime routine. Like I mentioned earlier, setting an alarm to wind down at night and another alarm to go to bed. Performing relaxation activities at night, such as listening to calming music, or some of my patients will choose to pray at night because that's relaxing to them. Keep the room temperature and humidity at a comfortable level. If acid reflux is present, then elevating the head with multiple pillows can help. But then, of course, following up with your doctor about managing the reflux is going to be important. Keep the room quiet, or you can consider a soothing sound machine as long as it's not distracting for the person with Lewy body dementia. Weighted blankets can help with anxiety and in turn could possibly help with sleep. Making sure the environment is safe. Of course, like I mentioned earlier, keeping sharp things away from the bed, things of that nature. But in this situation, also limiting lighting that can create shadows that could be misinterpreted as hallucinations or delusions. And cognitive behavioral therapy has been studied in insomnia with great promise. However, specifically in Lewy body dementia, it has not been studied yet. So we do need more research, but cognitive behavioral therapy does not have side effects. It is something that can be considered. You can see a psychologist who has that specific training on how to use cognitive behavioral therapy for insomnia to help. What cognitive behavioral therapy does, it really focuses on restructuring the thoughts or feelings and behaviors that are contributing to the insomnia. And therapy techniques often involve stimulus control or sleep restriction and relaxation training. Pharmacologically, there are no specific medications for insomnia in Lewy body dementia. But so first, you should always check with your doctor that you are not taking any medications that are causing the insomnia or contributing to the insomnia and keeping you awake when it comes bedtime. And melatonin is actually the first line of treatment for insomnia, given that it has a benign side effect profile, oftentimes starting at 3 or 5 milligrams about an hour before bedtime. And there are other medications that can be considered, but you should definitely talk to your doctor. Medication called trazodone can be tried to help with sleep. There's a medicine called mirtazapine that also can help with mood and appetite stimulation. There's a medication called quetiapine that can also help with hallucinations. And the medication called clonazepam, which is typically used for REM behavior disorder, can also be considered. Oftentimes, when we're trying to treat one thing, we want to use a medication that can also address other symptoms that are commonly encountered in Lewy body dementia to reduce the number of medications that an individual needs to take. How not to manage your insomnia. So one thing in common amongst all of these is that they all say PM or have Benadryl in them, or the generic word is diphenhydramine. So it is not recommended that you take these over-the-counter medications that are available easily to you because they can actually cause and contribute to your cognitive decline in Lewy body. Keeping in mind they work the opposite of the way that some of these memory medications that are prescribed to you are working. All right, we'll move on to restless leg syndrome. So what is restless leg syndrome? It's defined as an urge to move the legs when at rest or with inactivity. And it primarily occurs in the evening or night. However, over time, it can begin to affect individuals in the afternoons and mornings. The urge to move the legs is actually relieved partially or in totality by movement, but the movement has to continue. And it can be associated with distress, sleep disturbance, or functional impairment. For example, individuals may not be able to sit still because they need to move their legs. They may not be able to go to sleep or fall asleep because they need to move their legs. So how do you know if you have restless leg syndrome? Frequently, individuals will describe many of these symptoms. People will say they feel like bugs are crawling on their legs, and moving the leg while seated or laying down actually relieves that symptom. These individuals may have daytime sleepiness. They may experience aching in their legs or a tingling sensation in the legs, or even muscle pulling. They may feel like there's an itching or a throbbing sensation, and they have trouble falling asleep because of all these symptoms. And oftentimes it begins in the legs and it may stay in the legs, but there are reports of similar symptoms affecting other parts of the body, including the arms. So how do we manage this? First, like you may have noticed as a theme, it's always important to make sure you are not on any medications that can worsen this sleep disturbance. And in this situation, the restless leg syndrome. So there are certain antidepressants, antihistamines, antipsychotics, or metoclopramide or Reglan, another GI medication that could worsen restless leg syndrome. Other substances such as nicotine, alcohol, and caffeine may also be kind of impacting it, but limiting this can also improve your symptoms. And it can actually occur due to iron deficiency as well. So follow up with your doctor and have labs checked, including serum ferritin and a transferrin saturation percentage. These are ways how we can check if someone has an iron deficiency. Individuals have reported warm baths can help alleviate some of the leg symptoms. And pharmacologic treatments. So there are no studies looking at specific medications for restless leg syndrome in Lewy body dementia. However, if you do have iron deficiency, it is important to be on iron supplementation if it's indicated. There are dopaminergic medications that can be prescribed for the management of restless leg syndrome. However, people with Lewy body dementia may be sensitive to certain dopaminergic medications. Thus, oftentimes we prefer to use something called carbidopa levodopa. And if you're already on it, it's important to optimize its dosing or adjusting the timing of its dose to help also address the restless leg syndrome in addition to the Parkinsonian symptoms. Another medication that you may have heard about that's frequently used to treat neuropathy is called gabapentin or pregabalin or Lyrica that can also help with restless leg syndrome. But although it can be very well in addressing and treating the restless leg syndrome, it does have some side effects, which includes sedation and cognitive effects. So that's why we would like to limit its use during the day if possible. And now we'll move on to obstructive sleep apnea. So what is obstructive sleep apnea? Obstructive sleep apnea is defined as breathing that is interrupted during sleep by partial or complete collapse of the airway, and it's associated with drops in your oxygen levels. And it leads to waking up frequently at times, gasping for air. It's important to realize that the person who's experiencing this may not be aware of these arousals. We call them micro arousals, since they may be very brief. And it can lead to impaired sleep quality because you're waking up or you're being aroused multiple times at night. Can lead to excessive daytime sleepiness since you're not sleeping well at night. Can also lead to cognitive impairment and mood changes. The bed partner may observe that the person with obstructive sleep apnea may wake up gasping or choking and may witness snoring and or breathing interruptions during sleep. There are questionnaires to help screen for sleep apnea. There's one called Stop Bang, looking at aspects of snoring. Are you tired or fatigued during the day? Has anyone observed you stopping breathing or choking or gasping for air? And do you have high blood pressure? Because we know sleep apnea is associated with high blood pressure. And looking at weight, because we also know that oftentimes individuals who are overweight may also have sleep apnea. But we also know in Lewy body dementia that, and in many neurodegenerative diseases, changes really just anatomically may contribute to the obstructive sleep apnea. Are you greater than the age of 50? What is your neck size? And what is your gender? And this gives us a general idea of a low, intermediate, or high risk of the likelihood of obstructive sleep apnea. But keeping in mind that the definitive diagnosis is really made by a sleep study, where we would see more than 15 respiratory events or obstructive respiratory events, wherein an individual reduces their breathing or stops their breathing, where there's a reduction in their oxygen level per hour. And how do we manage this? So CPAP is the first line therapy for obstructive sleep apnea. And we know actually treating it actually has what research has shown leads to cognitive improvement, improvement in excessive daytime sleepiness, improvement in mood and quality of life measures, and actually improvement in sleep quality in the bed partners of individuals with obstructive sleep apnea. There are mandibular advancement devices, oftentimes created by dentists or a specific type of physician who specializes in this, but this has not been studied in Lewy body dementia. Weight loss can also help obstructive sleep apnea and reducing alcohol and tobacco use. So lastly, I really want everyone to understand, I know we've covered multiple aspects of sleep disturbances that are commonly encountered in Lewy body dementia, but I really want you to understand that sleep is important for everyone. And this includes persons with Lewy body dementia and their care partners. And sleep disturbances are historically underreported and underdiagnosed. So you should talk to your doctor. This includes your primary care doctor, your neurologist. Ask for a sleep medicine referral if you are experiencing any of these symptoms that were covered today. All right, and so that ends my presentation.
Fantastic. Thank you so much, Dr. Patel. That was excellent. All right, everybody, use your reactions button at the bottom. There we go, to show some love to Dr. Patel for taking time out of her busy day with us today. We really, really appreciate it. Oh, there we go. Nice job, guys. Fantastic. So if you don't mind to go ahead and stop share, then we will start a little Q&A here. So excellent. All right, so I'm going to pull up these questions because we got some really, really good ones. Oh, thank you guys so much. We have such a great community. Okay, so here we go. How common is central apnea for people with Lewy body dementia?
So central apnea is overall less common than obstructive sleep apnea. It can happen in Lewy body dementia, but there are no percentages that I can quote because this hasn't been well studied in this patient population. It is in relation to obstructive sleep apnea. It is less common just in the general population, but people can have central sleep apnea in Lewy body dementia as well. And they can have central sleep apnea with obstructive sleep apnea. And in those situations, we call it mixed sleep apnea.
Interesting. Thank you.
And
Thank
the
you.
only way to know is by doing a sleep study.
Okay. And you said you recommend that they do the one where they go into the clinic, not the one at home. That's not as sensitive. Is that correct?
Correct, correct. However, insurance companies sometimes may require you to do a home sleep study just depending on your insurance. And unfortunately, there may be challenges in going around that. So it's not infrequent where individuals may have to complete a home sleep study first. And if it's inconclusive, then the insurance company may pay for a in-lab sleep study.
Excellent. Thank you. Okay, so we got a question related to melatonin because you mentioned that. And so this question is, this gentleman had a negative reaction to melatonin. So he tried it at the lowest dose of 1 milligram and it made his dreams extremely violent. Is that something that you sometimes see?
Yes, that is rare, but it is something that can happen. These paradoxical reactions to melatonin, where people do have worsening of their vivid dreams. And then in those situations, we don't want to continue something that's worsening their vivid dreams, and we would move on to clonazepam.
Absolutely. Thank you. Thank you. And that's one thing I think you guys should always know is and Dr. Patel chime in here if you want. You guys are a sensitive group when it comes to medications and can have some really interesting reactions. So I think anytime you start an over-the-counter drug or a medication of any sort, track the symptoms, make some notes, the care partner if you see things changing so that you can discuss that with the doctor because definitely we hear some unusual reactions, I think sometimes too. Excellent. So this question is about REM behavior disorder. So does the occurrence of that and the violence of it increase with progression of the disease, or is it related at all with progression?
So, not necessarily. We know that individuals may experience REM behavior disorder and it may be violent 10, 15, maybe even more than that years before they even actually develop the disease of Lewy body. So, there is, as far as we have an understanding right now, there is not a specific correlation.
Excellent. Thank
They may
you.
be violent, they may be intense, and then they may become mild on their own. They may go away. Sometimes I've had people report they haven't had any issues with it for months, and then suddenly it comes back without rhyme or reason.
And someone else asked too, that their partner doesn't really act out violently, but is acting out their dream. So that's still REM sleep behavior disorder, correct?
Correct. Not everyone has violent enactment of their dream. It is not always violent. So you may read about how it's violent, but it's not always violent. That's very important to note. It's more that they're just enacting something purposeful that, that they are dreaming.
Excellent. Thank you for the clarity on that. So this is a really interesting question. So this gentleman is using his RBD says is virtually resolved with 6 milligrams of melatonin, but however, he's having low percentages of REM sleep and N3 sleep. Is that part of Lewy, or is that a problem? Because we know, like you said, sleep is so important, and getting some of those deeper sleep states. So is there anything that he can do to try to improve that, or is that just part of the disease?
It's part of the disease, but also when we're treating or targeting how to manage some of these REM behavior disorders, the goal of the treatment does reduce your REM sleep. So you're in REM sleep for a shorter duration of time, and so you're not acting. There's less of an opportunity to act out your dreams.
Interesting. Interesting. Thank you. Here's another question related to diagnosis, because you talked about how REM sleep behavior disorder can be one of those diagnostic criteria. So this gentleman says that the neurologist told them when he was doing the clinical diagnosis, that his wife's condition, that because she had REM disorder, that was the differentiator between other disorders and Lewy. And that's why he diagnosed her with LBD versus other dementias, because there's no biomarker for Lewy. Is that accurate, or do you sometimes see REM sleep behavior disorder with other types of dementias or progressive neurological conditions?
We can see REM sleep behavior disorder in other neurodegenerative diseases. Specifically, it's it's very specific for something called alpha-synucleinopathies. That includes Parkinson's disease and another disease called multiple systems atrophy, in addition to Lewy body dementia. Of course, there are case reports of it happening in other dementia syndromes, but frequently those three diseases, dementia with Lewy bodies, Parkinson's disease, and Parkinson's disease dementia, and multiple systems atrophy are the three that we most commonly see REM behavior disorder in. But as it relates to biomarkers, so having cognitive impairment in a specific pattern or dementia in a specific pattern that we would expect in Lewy body, plus having the REM behavior disorder that the doctor is suspecting based on some of the questions that they may have asked, and is enough to be concerned for Lewy body dementia. But getting a sleep study that proves that the person has REM behavior disorder can further solidify that diagnosis. As it relates to biomarkers for Lewy body conditions, there are a couple things that are available. One is CSF, looking for alpha-synuclein, and a skin biopsy test that's also looking for alpha-synuclein. So those two things can also help as it relates to the diagnostic criteria that are available for Lewy body dementia. Again, getting that sleep study and even a DAT scan or a dopamine scan can also help with that diagnosis.
Absolutely. Thank you. This is so you talked about insomnia, REM sleep behavior disorder. But sometimes people get to the point that they sleep a lot. So, and the days and nights can get mixed up. So, is there anything that you recommend for someone in later stages where they've really kind of mixed up their nights and days? And then also, I think, how can people prevent that from happening too?
Right. So sometimes we call that circadian rhythm disorders. It's not really well outlined in specifically Lewy body dementia, but we encounter this in all types of dementias. And sometimes we encounter this in individuals who are hospitalized or outside of their home in a nursing home setting or in a skilled facility where there's not enough exposure to daylight, and nights and days are more likely to get confusing when your windows are always closed and the blinds are always closed. So definitely, making sure that you're having those alarms set about waking up at the same time, maintaining that routine is going to be very important. Waking up at the same time every day, making sure that naps are very limited, setting an alarm for the nap. Let's say you wake up at 9 o'clock, and then if you need to, you can schedule naps. So having scheduled naps can really help, because a person with Lewy body dementia may expect to take a nap at 12 o'clock, and then just setting that expectation that they will need to wake up, let's say at 12:30 or 12:45, and just scheduling those naps are going to be very important. Having activities for those individuals to do during the day, whether they're physical activities, movement, stretches, or even, coloring or playing a puzzle or interacting with others, grandchildren, family members, friends, going out just for lunch or grabbing a coffee outside or going on a little trip around the corner kind of thing can also help. Just having scheduled activities where they're exposed to daylight, and exposed to daylight can also stimulate vitamin D. There's multiple benefits from exposure to daylight. So that will be very important to help kind of break that cycle. If you are in like a hospital setting or a skilled facility, important to kind of mimic some of those things in that environment as well. And oftentimes it really relies on the care partners or the family members to help facilitate that by, opening up the blinds, things of that nature.
Absolutely. Thank
In
you. And that's
addition,
some, oh,
melatonin is sometimes used as well to help. If you're not on melatonin previously, oftentimes we will prescribe melatonin to help regulate that night and sleep, that night and wake cycle.
excellent. I'm so glad you brought up routine and that need for activity. Next week on Tuesday, we have an occupational therapist with us who's going to be talking about engaging in activities. And we've talked a lot this year too about, involving that allied rehab team. Physical therapy can give you exercises, activities to do, OT, speech. Sometimes if you're not sure what to do with your loved one or how to kind of build that routine, that can be something they can help out with. We got a great question here about naps because you kind of mentioned scheduling those naps with the routines. So this gentleman, it sounds like, is napping for a couple of hours in the daytime. Should that be limited? Is that maybe a problem?
So limiting naps is important, specifically in the setting if it's impacting your nighttime sleep. So as disease advances, sometimes it gets challenging. Some of the recommendations are no more than 30 minutes or no more than an hour. However, in this disease, as it's advancing, it does become harder to wake up someone after a 30-minute nap because they're still sleeping. I don't. I try to limit naps to an hour if possible. And as long as it's not impacting their nighttime sleep. If it's not impacting their nighttime sleep, it's okay if they need to nap for an hour, hour and a half. I prefer it to be earlier in the day because that's also less likely to impact their nighttime sleep. If it's impacting their nighttime sleep, then that's when we really need to get more aggressive, because that nighttime sleep needs to be really good quality of sleep in order for those, garbage collectors, like I explained at the very beginning, to come out and do their job.
Excellent. Thank you so much. Are there any medications that can help you stay asleep during the night? So this gentleman says he's taking trazodone and melatonin, and they help him fall asleep, but they're not helping him stay asleep.
And so sometimes we want to address the timing of medications like trazodone and melatonin. Sometimes people may have no trouble falling asleep, then it might be better to take those medications at the time of going to sleep and not an hour before bed, because we don't want it to kick in too early, because this individual isn't having problems falling asleep. And the bigger problem is staying asleep. Sometimes if an individual wakes up early early at nighttime, then we can redose one of the medications as long as it's not too late and it's not going to impact their daytime activities. And there are other medications, like I mentioned earlier, that could be also used depending on what other symptoms an individual may be experiencing, such as mirtazapine, quetiapine, clonazepam. And also adjusting the dose of those medications can also be useful, including trazodone and melatonin.
Great advice. Great advice. We've got a lot of questions here about hallucinations. And I know there can be a lot of interplay between, some of the psychiatric symptoms like hallucinations and sleep. So, what can be done, I guess, for people who hallucinations are disrupting their ability to fall asleep or have good sleep at night?
So one of the main things I think it's important to differentiate is this quote unquote hallucination that oftentimes a care partner is observing? Is it a hallucination when they're like asleep, or are they awake? Because if they're asleep, is it part of their REM behavior disorder? So that sometimes can be confusing to differentiate. So it's first of all very important to determine, is it that there is the person with Lewy body dementia asleep, or are they fully awake? If they're asleep, like I said, managing the REM behavior disorder is going to help with those vivid dreams that may carry over, where an individual may feel like, they were being chased by a bear, for example, and that bear is there. So treating the REM behavior disorder part is going to be important. As it relates to the hallucinations that can happen that prevent an individual from falling asleep, that again, there's a couple things that can be done. One is the bedroom safety. Again, oftentimes there's things in the room that may be triggers to these hallucinations, whether it's poor lighting or a lampshade, or light coming in from the window that may be distracting, or just emitting a different type of a shadow that you may not think anything about, but the person with Lewy body dementia's brain is perceiving it to be something that's not true. So definitely the bedroom safety aspect of it is going to be important, and the lighting. And furthermore, there are certain medications. So medications that are used to treat hallucinations can also cause sleepiness. And so you can consider a medication like quetiapine by talking to your doctor that can treat both hallucinations and cause you to feel sleepy. So it makes it easier for you to fall asleep.
That's really helpful. Thank you so much. A question here, I think there was a slide that you put up that had some different medications, like over-the-counter things that people shouldn't take. And this individual is asking if Tylenol was on there. Were you saying that individuals with Lewy should not take Tylenol?
Not Tylenol, Tylenol PM. So all the medications that I had up on there said PM afterwards, or it was Benadryl. So PM, actually, anything that says PM, very commonly, most 100%, I'd say, has something called diphenhydramine on it, which when you read the ingredients on the back, diphenhydramine is Benadryl. Benadryl in people with Lewy body dementia should absolutely be avoided because it can worsen the cognition and the behavioral symptoms. And like I mentioned earlier, it works opposite to the memory medications that we frequently prescribe.
Excellent. Thank you so much for that. You mentioned CPAP and talked about that a little bit. And so what if the individual refuses to use a CPAP? What if they won't use the device? Are there any other options?
So I think the evolution of CPAP technology has really grown in the last several years. So I would really reconsider using the CPAP. I think it's really important to recognize that it's not something that you're going to love wearing from the first day, but most people after 2 to 3 weeks are adjusted to it, and it's not, the benefits outweigh the risk of it. But I think it's important to follow with a sleep medicine doctor that you trust and can try various different types of CPAPs CPAP masks that are available. Oftentimes people may feel claustrophobic, but now they have smaller ones that are available, or just nasal ones that are available. So like I said, the technology has really evolved and the devices have become smaller, less intrusive. So I think it's important to first make sure you've tried all of those before you say, no, I'm not going to try it at all, because give it a chance. You may find one that you like. There are mouth guards, or those mandibular devices, that may be useful, but it's difficult to say since there hasn't been rigorous research done on them. But it might work better than nothing. Sometimes your sleep medicine doctor may comment on, oh, if you sleep on your side, that may reduce, the risk of apneic episodes or periods of time where you stop breathing or reduce your breathing at night. So sleeping positions may also be helpful.
Thank you so much. Really, really helpful. I'm getting a lot of questions about melatonin. So someone has asked if some people have the opposite effect from melatonin. And so it looks like a big yes.
Yes.
And then we have this gentleman says his wife does not want to take melatonin because she's afraid it'll make her sleepy in the morning. Is that a side effect that can be a problem for some people?
So all medications that we use to help with sleep all carry that potential risk of causing daytime sleepiness. Excuse me. And so what we like to consider doing is moving up the dose or the timing of the dose. So for example, if they take it at 10 o'clock and the effects linger till 8 a.m., then I'd recommend taking it at 8 p.m. So that way the effects will only linger till 6 a.m. So just moving up the timing of some of these medications, or even melatonin, is going to be important. So that way it's not impacting their daytime activities.
Excellent. That's really, really helpful. I think, that this is where those conversations with your doctor are so important, and tracking things too of when you're taking it and stuff. They can really help a lot more.
Exactly.
Fantastic.
So the dosing and the timing, I think we underappreciate the value of timing of medications. Even moving up a medication by an hour may make a huge difference, or moving it an hour later may make a huge difference.
Absolutely. We had a question here too about on the melatonin topic too, and we'll try to wrap that one up. Someone asking about a continuous release melatonin. Is that something that you know of or recommend?
So there are immediate release and extended release formulations. They haven't been studied. In theory, an extended release formulation does release slowly over time throughout the night. But because there hasn't been rigorous studies looking at one over the other, it's difficult to recommend one specifically. Just from experience, oftentimes patients don't always notice a big difference between the two, but I have had some people notice a benefit with the extended release. So I think you can always try it. It's not going to hurt. One of the main things you want to watch out for is that lingering effect into the daytime.
Great advice. Great advice. So this person asked that, or comments that most of the sleep medications that you mentioned made her father have increased anxiety and sometimes more hallucinations. Are there other sleep medications that or there some of the sleep medications, I guess, that have less of those side effects than others?
So some of them do. So like trazodone or clonazepam is actually, used to treat anxiety as well. And so it's not a great medication that we love to prescribe long-term just for anxiety, but that can be something that can be tried. Mirtazapine is also frequently used to treat specifically the anxiety, and quetiapine can be used as an adjunct for mood disorders. So they all do have some varying degree of impact on anxiety. If anxiety is not controlled overall, then having another medication to treat the anxiety part is going to be important. It's not uncommon where people may feel like they don't have anxiety during the day, but it happens at night, because that's when, they're left with their own thoughts, and, they may start thinking about certain things and become anxious at nighttime.
Good advice. This is a question that is near and dear to my heart because I'm always asking my husband if I was acting out my dreams at all. So this individual is asking what's the correlation between REM sleep disorder and the development of LBD? And I think you kind of touched on it with those synucleinopathies.
Right. Yep. So there's been lots of studies following, looking retrospective studies looking at individuals who develop these alpha synucleinopathies, meaning Parkinson's disease, multiple systems atrophy, or dementia with Lewy bodies, and looking back, nearly up to, some reports will say 70%, some reports say 50%. One study even quoted 90% at 15 years have had REM behavior disorder in their lifetime.
Absolutely. That is why I'm always, my husband sometimes will say I was laughing in my sleep. I'm like, but was I acting out my dreams?
Yeah.
Getting to the neurologist if so.
Yes. Yeah.
Um, we have a really good question here because you talked beautifully about so many of those non-pharmacological or non-medical interventions. And so exercise, those earlier bedtime, sleep hygiene. So I dealt with this as an occupational therapist a lot with my clients. When you have someone who is not active, they're a night owl, they're wanting to stay up all night. What are some, she says, respectful ways, which I think is very kind, to kind of introduce exercise and those earlier bedtimes and maybe work in some of those habits that will help sleep more?
I think it's good to be realistic when setting those goals, first of all, so let's say if someone is a night owl, and they go to sleep, let's say at 2 a.m., then I think part of it is if they're sleeping from, let's say 2 to 10, uninterrupted, getting good quality sleep, waking up refreshed and continuing on with their whole day energetic, then I think it's okay. We don't have to be very aggressive about forcing something when their natural circadian rhythm is set to go to sleep at 2 and they wake up at 10, for example. But if they are not getting good quality of sleep and they're struggling during the day with excessive daytime sleepiness, not being, and it's impacting social interactions, etc., then I think it's important to start setting like a goal of going to bed, let's say 15 minutes before the time that they go to bed, or even moving it up to 30 minutes, then 45 minutes. Setting a realistic goal is more likely that the person will achieve it. And then that gives, that provides that positive reinforcement of, getting that good quality of sleep. If they start feeling like, okay, well, I can do this and I am sleeping better by doing this. So doing that, I think, is important. And then, really enrolling individuals in support groups and just exercise programs that can, that gives them an accountability of needing to be somewhere at a certain time can also help. And the actual activity can also help stimulate their brain to the point where, they're more awake at certain points of the day. And then it fatigues them enough come later on in the day that they actually want to go to bed earlier.
Excellent. That's really great advice. And you guys, I know apples and oranges a little bit, but with Parkinson's, some of the research with sleep has actually been on even intensity of exercise. So to your
That's
point,
correct.
having that activity, and that has to be per the individual, but we do want them to have, I used to call it peaks and valleys in the day. You want them to have some activity and engagement and exercise and then some recovery time too. So all really great
Absolutely.
advice.
And
One last question. Oh, go ahead.
I was just going to say in Parkinson's disease, the high intensity exercise that's been recommended is 150 minutes per week. When we speak about individuals with dementia syndromes, we recommend 150 minutes of moderate intensity exercise at least.
Fantastic. Fantastic. And you guys, we had that recent webinar on exercise. And so Dr. Joellen Fox gave you a lot of great tips on that. You can go back and revisit that video if you want. And then I just want to ask you one last question, and then we're going to wrap up here. A lot of the drugs that you talked about, avoiding kind of those over-the-counter ones or those allergy medications with diphenhydramine. Are there any allergy medications that are safe for people with Lewy body dementia to
Right. So
take?
some of the newer allergy medications that are the newer generations or second generations of antihistamines are safer in Lewy body dementia. So things like Allegra, Zyrtec, et cetera, are okay.
Excellent. All right. Thank you so much. That was fantastic. And unfortunately, we're out of time. So please use those reactions again. Give her a little bit more love here before we wrap up. And we just so appreciate you taking time out of your day to share all of this incredible information. So, on behalf of the Lewy Body Dementia Association, I want to thank you all. And as a reminder, you're going to receive an email in about a week with a link for the recording of this presentation, along with the resources that we mentioned in today's webinar. We invite you to visit that new landing page on our website to stay informed about what's coming up next. And mark your calendars and join us quick and early here next Tuesday, August 20th. We'll be right back in your home with you at 2 o'clock, and we're going to explore some strategies for staying engaged with Lewy from occupational therapist Rachel Wiley. And so I think that'll help even fill in some of the blanks with this talk today, where she was talking about having some engagement, some activity. Hopefully you can get some good ideas for that. So take some time, fill out that survey as you log off. But I just want to thank you all for joining us, and we hope to see you again on Tuesday. And thank you again, Dr. Patel. It was lovely seeing you.
Thank you for having me. Bye.
Thanks so much.